Welcome to this satellite symposium presented by Natera. Clinical impact of quantifying donor-derived cell-free DNA in multi-organ transplant rejection assessment. Our moderator today is Haas Tiberziani, Medical Director of Organ Transplant at Natera. The speakers for today's session are Philip Halloran, University of Alberta, Gaurav Gupta, Hume Lee Transplant Center at VCU, and Pedro Ventura Aguiar, Hospital Clinic de Barcelona, Spain. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly to the session moderators, please use the Q&A feature on the side panel of your screen. Enjoy the session.
Hi, welcome to our presentation. I'm Haas Tiberziani, a transplant nephrologist and the Medical Director of Organ Transplant here at Natera. Today, I have three of very well-known speakers with us in this presentation, Dr. Phil Halloran, Dr. Gaurav Gupta, and Dr. Pedro Ventura. I want to talk about the Prospera withQuantification. Briefly about Natera, we are the leader in the cell-free DNA technology. We have performed more than 5 million clinical cell-free DNA testing. We're a leader in publishing scientific data across the cell-free DNA application, and we have more than 250 technology patents, which more than 100 of them have been issued. We are using novel molecular method combining with proprietary bioinformatics with a custom library preparation using multiplex PCR to have a precise results be reported. Here at Natera, we are constantly looking for innovation. As you can see, in 2009, we used this technology with the spectrum test, looking at the cell-free DNA for pre-implantation genetic information. In 2017, we launched using the same technology, looking at the cell-free DNA of the cancer cell in the patient with a history of cancer. And in 2019, we actually used the same technology, looking at the cell-free DNA of the kidney transplant recipient to look for rejection. In 2020, we also launched a broad spectrum genetic panel, Renocyte, which is looking at more than 385 gene mutation, which can cause kidney disease, electrolyte abnormality, and nephrolithiasis. Last year, we launched the Prospera, which is the cell-free DNA testing for the patients with a heart transplant and also for the lung transplant. So as you can see, we are always looking how to improve our test and how to use this technology, helping patients in different fields of medicine. So how does Prospera works? When we receive the recipient blood sample, it contains a mixture of both donor-derived cell-free DNA and also the recipient cell-free DNA. We're looking at more than 13,000 SNP. With dual single nucleotide polymorphism area, we can differentiate which of these cell-free DNA are coming from donor and which one are coming from the recipient. After differentiating these two, we report that as a fraction. If more than 1% come from donor, we call it high risk for rejection. And if it's less than 1%, we call it low risk for rejection. Because of our knowledge of cell-free DNA, we found that there are patients who have extremely high total cell-free DNA. And why is it important? Because when we report a fraction, anything that increases the denominator, which is the total cell-free DNA, can decrease the whole value of the fraction, which is going to be reported. So that increases the chance of the false negative results. What are those factors that may influence the total cell-free DNA? As you can see in these slides, those are very common things that can happen in any patient with kidney transplantation. I want to emphasize that these factors may influence the total cell-free DNA. It doesn't mean that, for example, everybody with high body mass index has high total cell-free DNA, but it increases the chance that these people have higher total cell-free DNA. Any infection, inflammation, anything which increases cell turnover, like surgery, trauma, even hemodialysis, even the shipment and storage of the samples can affect the total cell-free DNA. Having all of this information, we look at a 200 biopsy match sample, which we had in our training set, to find out what is the absolute quantity of donor-derived cell-free DNA, which can put the patient in the high risk for rejection. And by reporting the absolute number of these donor-derived cell-free DNA, these are independent of the total cell-free DNA, so we eliminate those causes that can affect the total cell-free DNA. In our exploration, we found that the copies of more than 78 copies per ml, which is coming from donors, can put the patient in the high risk for rejection. So our algorithm for high risk for rejection is if the fraction is more than 1% or the absolute quantity of the donor-derived cell-free DNA is more than 78 copies per ml. I want to emphasize that this is an or, and any of these factors can put the patient in the high risk for rejection. Thank you for your attention. And now I pass to our next speaker. Our next speaker does not need much introduction, and everybody knows Dr. Phil Halloran. Dr. Halloran is going to talk about the clinical impact of combining quantity with fraction of donor-derived cell-free DNA in kidney transplant assessment. Dr. Halloran is a transplant nephrologist trained in Toronto and London. Currently is a professor of medicine at University of Alberta in Edmonton, Canada, and is the director of University of Alberta Transplant Applied Genomics Center. His major research focuses on molecular microscopic diagnostic system, MMDX, and he's one of the founding editors of American Journal of Transplantation. Dr. Halloran.
Well, thank you very much, and thanks to everybody for the invitation to address you. I'll be talking about how we're adding quantitation of cell-free DNA in the trifecta study. And these are my disclosures. There are many people who've contributed to the trifecta study, and I can't name them all, obviously, but I'm extraordinarily grateful to these people in these international cities across North America and Europe. And of course, this is our team here in Edmonton, and it's a remarkable set of people. We're supported by research grants from Natera, by the licensing agreement with One Lambda, and by the Industrial Research Program of the Government of Canada, and by an endowed chair. Trifecta is an investigator-initiated international prospective study to calibrate plasma donor-derived cell-free DNA against the molecular findings in the biopsy. The study is trifecta because it includes HLA antibody measurements by One Lambda, interpreted by Louis Hidalgo at the University of Wisconsin. And I'm going to be talking about the first 300. So these are the three relationships that we're trying to work out. And to this, we're working out now the addition of the quantity of cell-free DNA in addition to the percent of these that cell-free DNA from the donor is of the total cell-free DNA. And of course, the problem we're addressing is the fact that we're now recognizing that a lot of antibody-mediated rejection is DSA negative, as you'll see. So our first analysis was published in JASN a couple of months ago. And what we're finding is in the first 300 biopsies, we had a double analysis, percent cell-free DNA versus the MMDX findings in the biopsy. The top transcripts correlating with cell-free DNA, as they're expressed in the biopsy, had all been previously associated with antibody-mediated rejection or all rejection. The percent donor-derived cell-free DNA correlated with both molecular and histologic rejection, more so with molecular than histologic. And the percent donor-derived cell-free DNA is most strongly associated with antibody-mediated rejection, but was also elevated in biopsies with active T-cell-mediated rejection, and a number of other biopsies probably reflecting some form of injury. Now, in our new paper, which is about to be submitted, we call it Trifecta 2, and it's the first triple analysis of DSA, donor-derived cell-free DNA, and MMDX. in the first 280 biopsies in which we've got the triple results. This is the 300 biopsy cohort we published, but in 20 of those, the DSA measurement was not successful. So we're now presenting the 280 triple results. And I'll be showing you the first results on quantity of cell-free DNA as well as the percent. So I'm just showing you here the previous analysis was based on this set of studies, MMDX, local assessment, local DSA, and on the cell-free DNA. And now we're adding the central antibody measurement and DSA interpretation. So what we're asking is, how often do we see DSA negative antibody-mediated rejection? Does DSA negative antibody-mediated rejection release cell-free DNA? Is there a difference between central readings of DSA negative and local readings? And the number of positives that you get with antibody-mediated rejection for cell-free DNA versus DSA. And then we're going to use logistic regression to get the best predictions. So the first results indicate that DSA negative antibody-mediated rejection is surprisingly common. 56% of the antibody-mediated rejection is DSA negative. And that's whether you use molecular or histologic readings, you get a similar number. But the DSA negative antibody-mediated rejection is just as positive for cell-free DNA as the DSA positive antibody-mediated rejection. Central and local agree 97% of the time. So this is not a central versus local issue. It's a robust finding that these plasmas are negative for antibody. Now, antibody-mediated rejection is 75% positive for cell-free DNA versus 44% positive for DSA. But then let's look at how those two perform in logistic regression. This just illustrates the three styles of antibody-mediated rejection diagnosis we have: the sign-outs for the MMDX, the automatic rejection archetypes assigned by the computer, or histology readings locally. All three of them reach the same conclusion. There's a lot of cell-free DNA, cell-free DNA release by DSA negative antibody-mediated rejection, whether you look at MMDX, at archetypes, or by histology. And there's no significant difference between DSA positive and DSA negative in the amount of cell-free DNA release. I'm just illustrating for you now what these 4 different assessments that we're using actually amount to. We're seeing 80 biopsies that have antibody-mediated rejection activity, including mixed, 39 biopsies that have T-cell-mediated rejection, including mixed, 104 biopsies that are positive for cell-free DNA at the cutoff of 1, and 60 biopsies that are DSA positive. And I'm illustrating for you the number of biopsies that are positive for each of these tests. 44% positive of all the ABMR mixed are DSA positive, and 75% are positive for cell-free DNA at a cutoff of 1. So then going into logistic regression, and this is a complex table, but I'll walk you through it. We took 4 predictors: time post-transplant, DSA positivity, percent donor-derived cell-free DNA, and quantity donor-derived cell-free DNA. The AUCs, respectively, were 0.61 for time, 0.66 for DSA, 0.84 for percent donor-derived cell-free DNA, and slightly higher for donor-derived cell-free DNA quantity. Now we started to combine them. So we added DSA to percent donor-derived cell-free DNA, and the AUC went up a little bit. We added quantity to the combination, and the AUC went up a little bit more. And the best logistic regression prediction that we had was when we combined donor-derived cell-free DNA percent, DSA, donor-derived cell-free DNA quantity, and time. And that gave us an AUC of 0.88. for antibody-mediated rejection. And so what we interpret that as using the p-values of the comparisons between these different models. Donor-specific antibody adds somewhat to cell-free DNA. Cell-free DNA adds massively to donor-specific antibody as a percent. Quantity of cell-free DNA adds slightly to the combination of percent cell-free DNA and DSA. And the best prediction, significantly better than the others, uses time, quantity, cell-free DNA percent, and DSA. I know that's a little complicated, but what we're saying really is that we're getting better predictions by cell-free DNA than by DSA alone. We get better predictions when we combine them, and when we add quantity, we get the best predictions. Time adds a little bit as well. Okay, so the next paper will be Trifecta 3, and it's under review. And what we're trying to do in this is a double analysis of cell-free DNA compared to the molecular and histologic phenotypes of the biopsy. And we're adding the percent cell-free donor-derived cell-free DNA and the quantity of donor-derived cell-free DNA. Now, this is in our first 367 biopsies that meet the criteria after exclusions to simulate clinical test performance. So this tells you how it will perform using the existing rules for how the test should be used. So this is the manuscript that's been submitted and the authors. Very grateful to all of these authors. And this is how we are doing this study. We're taking the 367 relevant samples after exclusions to simulate intended use. We're creating a training set of 149 and a test set of 218, and the training set and the test set are similar. So we started off with 426 biopsies at this time for which we had results, and we've included 367 after excluding 59 that had been collected before 14 days. They were from patients with cancer, they're from patients with multi-organ transplants, from pediatric patients. They had longer transit times than was acceptable for the test quality, or they're from patients with BK. Now we're showing you the performance of two threshold algorithm in which we've set thresholds for the quantity and the percent. And we're showing you for the total, for the training set, and most particularly for the test set, for the molecular, predicting the molecular phenotype and the histology phenotype. And you can see there's a lot of results here. In general, the test set was better for the molecular phenotype than the histology phenotype. We're also showing you using, without cutoffs, the logistic regression to predict in the test set and test the equation, in the training set and test the equation in the test set. When we test the training set equation in the test set, we get an AUC of 0.88 for molecular phenotype and 0.82 actually for the histologic phenotype. This just shows you the ROC curves for predicting molecular in red and histologic rejection in the test set, based on a logistic regression model built using the donor-derived cell-free DNA fraction and quantity together as numbers in the training set, AUC of 0.88 and 0.82 respectively. Let's have a look at how these actually perform. If we line up the biopsies in 2 dimensions by their quantity of cell-free DNA or by their percent donor-derived cell-free DNA, we can see that we're coloring these by their molecular phenotype. Now the lines indicate where the usual cutoffs would be for these 2 tests. And you can see that using a cutoff of 1 will, for the percent, will miss some cases that are picked up by the quantity using a cutoff of 0.78 for the quantity would miss some cases that would be picked up by the percent. And you get the most bang for the buck, in a sense, by using both the quantity with a cutoff and the percent with a cutoff. The results are similar with histologic diagnosis, except the histology, as you'd expect, is a little more noisy. But you're picking up extra cases when you use the cutoff for quantity of cell-free DNA, and you add that to the cutoff for percent cell-free DNA. So here are the conclusions so far. Cell-free DNA is strongly related to active molecular or histologic rejection, more strongly to molecular than histology, but strongly related to both. And we're showing that in trifecta 1. The percent cell-free DNA is as high in DSA negative antibody-mediated rejection as in DSA positive, and considering that a little more than half of antibody-mediated rejection is DSA negative, that's an important finding. The cell-free DNA percent and quantity both strongly predict ABMR in trifecta 2. But in trifecta 2, quantity is slightly stronger, and the combination is the strongest when we're developing regression equations in logistic regression. So the combination of the two adds value. And both quantity and percent predict rejection in the biopsies selected for intended use in trifecta 3. And again, the AUC is best for the combination and logistic regression when it's trained in the training set and tested in the test set. The AUC is 0.88 for the combination. So thank you very much.
Our next speaker is Dr. Gaurav Gupta, who's going to talk about investigating cell-free DNA in multi-organ transplant recipient, and also talk about the tortainovirus TTV as a biomarker for immune status of the patients. Dr. Gupta has received his medical degree from All India Institute of Medical Sciences. He finished his residency and nephrology fellowship at University of Pittsburgh and continued his education by a transplant nephrology fellowship at Johns Hopkins University. He's currently the medical director of kidney transplantation at VCU, and Dr. Gupta's current research focuses on increasing access to kidney transplantation and molecular diagnosis in kidney transplant recipient. Dr. Gupta.
Good afternoon, everybody. Thank you to Natera for the invitation to present this talk today. So I'm going to talk about some non-invasive biomarkers today with a focus on multi-organ transplants, as well as biomarkers to assess the immunosuppression burden that patients with transplants may be on. These are my disclosures. So I'll start with some background first. So why do we need biomarkers to detect early injury? As most of the audience probably knows, the reason is that subclinical injury can continue for a long time before it's detected by routine markers like serum creatinine for kidney transplants and change in heart function for heart transplants. So we need to catch patients when they are in this dark blue zone, which is depicted on the slide in the middle, so we can avoid clinical injury and graft dysfunction. This can be seen nicely in this graph, where creatinine measurements barely change between measured GFRs of 180 on the right all the way to nearly 60 or even lower on the left. And it's only when GFRs are substantially compromised below 60 or 40 is when serum creatinine goes up, and therefore it lags behind substantially with regards to early detection of injury. So as you may know, there are 3 commercial tests at this time that exploit these technologies, and they're listed here. And at least based upon the fractional data, the performance characteristics of these tests apparently are similar. So this is the data for kidney transplants. This is a meta-analysis which looked at the pooled median estimates using two methods, weighted median of medians, or WMM for short, and quantile estimation, or QE for short, of fractional percentage of dd-cfDNA to predict different disease states. So you can see the upper left corner, where stable patients had an estimate of around 0.3% or so. Patients with T-cell mediated rejection on the right upper corner were not very different at around 0.3% again also. On the other hand, antibody-mediated rejection patients, which is the left lower corner, these patients stood out with very high cell-free DNAs of above 2% on an average. So this data suggests an ability to distinguish ABMR from normal, but less so for TCMR, for kidney transplants. And several papers have been written about this, but it's beyond the scope of my discussion today to talk about those nuances. A second large multi-center study showed that stable heart transplant patients have a very low median cfDNA of just 0.07%, which can be seen in the upper left corner of this histogram. This analysis included nearly 2,000 samples from around 740 patients in this multi-center cohort. And the authors found that at a 0.2% threshold, dd-cfDNA had a 44% sensitivity to detect rejection and a 97% negative predictive value to rule out rejection. So as a test, this was excellent to rule out rejection, but less so to rule in rejection. And that theme remains the same across multiple studies with regards to a very high NPV, but a lower PPV across different organs and studies. So what about liver transplant? In liver transplant, the data is slightly different. In this prospective study of 128 patients, dd-cfDNA was found to be much higher, all the way up to 80% at the time of transplant to below 10% after a few months of transplant. And the reason is that there's a relatively higher dd-cfDNA amount in the liver transplant compared to other organs due to a much larger graft volume, as well as a very high regeneration rate of hepatocytes in the donor organ. And therefore, those numbers need to be reassessed in the context of liver transplant. The same group looked at rejection rates also, and they found that stable patients had lower cell-free DNA compared with both hep C positive liver transplants, as well as those with liver rejection. The cutoffs for rejection for non-hepatitis C positive patients was around 11%, as can be seen in the table in the top row. And for those with hepatitis C was around 23.6%, with sensitivities and specificities that were fairly good for this study. So the rationale for those with hepatitis C having higher amounts of cell-free DNA even without rejection was because of chronic hepatitis C, which was recurrent after liver transplant. Again, this data is less valid today because now most patients with hep C can get treated right after transplant or have already been treated before transplant. Similar data in the newer era where hep C can be treated, as I mentioned, was reported just a couple months ago by Dr. Levitsky from Chicago. And here, those with acute rejection versus those with normal function or TX, which can be seen in the top row of this table, were differentiated at a cutoff of around 5%. Those with acute rejection versus acute injury but no rejection, or ADNR, in this table were differentiated at a cutoff of 20%. And finally, those with acute rejection versus all others, be it ADNR or TX, were differentiated around 15%. So once again, the point remains that it is possible to detect liver rejection or injury using cell-free DNA measurements of different kinds. So all of this data I've shown you so far is on single organ transplants, liver, heart, kidney. But what I haven't shown you is data on multi-organ transplants because it doesn't exist. And that's the void that the current study that we are doing tries to fill. So we don't have any data for multi-organ transplants from the same donor or from different donors. And this is why the multi-organ transplant detection study was designed, or MOTOR for short. And this is a multi-center study which includes around 17 centers at this time. We are a part of this, and you can see the enrollment as of the most recent past here, based upon different centers which are in this including both Canada and the US. So I'm going to show you very preliminary data that has not been analyzed in any detail yet for the study. So far, a total of 320 patients have been enrolled. A majority of them are kidney and pancreas, as can be seen in the top row. But a fair number of kidney livers and kidney hearts have been included. Of these, again, a majority have been included with those with stable function, which is the third column from the left. And slightly less than 1/4 of patients enrolled were either receiving a surveillance biopsy or a for-cause biopsy at the time of the sample draw. So you can see the same distribution in a graphic format here. Heart kidney patients, which is the right bar, those patients had more biopsies. And this is likely because most centers perform surveillance biopsies on hearts, but not so on KPs or kidney livers. So I'm going to now switch gears and talk about a test that may help us measure immunosuppression burden in transplant patients. And the test that may do that is you measuring a virus called torc-tinovirus, or TTV for short. TTV is a non-enveloped human DNA virus isolated by Nishizawa in this paper from 1997. And since then, TTV has been classified as the alpha torc-tinovirus genus within the anilovirus family. This virus is characterized by an extremely high prevalence of above 90%, with relatively uniform distribution worldwide. TTV viral load increases under conditions of compromised immune response. And it's also been shown in some studies that replication of TTV is inversely correlated to both the number as well as the function of T lymphocytes. So this was first studied in this paper by Devlemink in 2013. This was a landmark study on close to 100 thoracic transplant recipients, lungs and hearts. And the authors looked at these patients with their plasma cell-free DNA longitudinally. And this was all cell-free DNA, be it human or non-human. And the non-human DNA could be bacteria or viruses. And I'll share the data with you in the next few slides. So they used sequencing of cell-free DNA in plasma, and they wanted to investigate, one, the distribution of viruses and bacteria, but then also to investigate the drug-virome interactions in these patients. Close to 660 some samples were included from 96 patients. Of those, 41 were hearts from adults, 24 from pediatrics in heart transplants, and 31 lung transplants. They observed marked virome dynamics at the onset of therapy and found that the total viral load increases with immunosuppression. And I'll show some of the data with you in the next few slides. On the other hand, the bacterial component of the microbiome remains unaffected. The most interesting thing that I want to highlight is in this blue rectangle at the bottom, where the bulk of the virome in these patients is formed by torc-tinoviruses, as can be seen in the brown shades in this table. So for patients on low doses of immunosuppression, herpes viruses and caudoviruses dominate the virome. But on the other hand, patients on high doses, the spectrum changes over time. And what I want to show you again is in this blue bar and the table on the y-axis, where as the immunosuppression dose increases, the distribution changes to mostly aneloviruses, where TTV is the primary virus in there, as can be seen in the orange color in these pie charts, where the predominant virus with increasing dose of immunosuppression is anelovirus. The same can be seen with time post-transplant, where early on there's not a lot of anelovirus, but over time the spectrum continues to change, with it becoming the predominant virus in the blood. You can once again see those temporal dynamics here in a better format, where early on, when the intensive immunosuppression is high, and you can see that in the top right corner of this graph, where once again in the orange color, aneloviruses are initially low at the time of post-transplant, and then around 3 months they become the predominant part of the virome, which then starts shrinking over time as immunosuppression burden goes down to around 12 to 15 months post-transplant. On the other hand, in the bottom two graphs on the left and right, you can see the bacterial distribution does not change significantly over time and is not associated with immunosuppression changes. This is even more striking for those with rejection versus without rejection. So you can see here on the left that the rejectors are shown with the red lines, and the non-rejectors are shown in blue lines and blue bars. And what's being seen here is interesting, that TTV does not go up as much over time in those with rejection versus those without rejection, where it goes up and then it goes down over time. So essentially the message is that if the virus doesn't go up significantly, that may be because of the fact that these patients are not on enough immunosuppression and may need more immunosuppression, and that's why they reject. So in a sense, TTV becomes a possible predictor of those who reject versus those who don't. And this is even more striking when you look at the gradation of rejection on the right, where those with mild rejection had higher TTV viral loads compared to those with severe rejection. And the AUC to predict rejection was fairly reasonable on the graph, which is at the bottom right corner. The same trends are seen in bone marrow transplants, where TTV goes up early, but as T cells repopulate, TTV goes down over time, and you can see that in the graph on the left in the blue line. But when we look at those with graft versus host disease versus those without graft versus host disease, there is a difference. Once again, those with GVHD in the red line have less of a bump in TTV viral loads over time compared to those without GVHD, indicating that even in this population, TTV may predict who will have GVHD versus who won't. What about kidney transplants? So the investigators from Vienna did the study on kidney transplant patients. A total of 386 patients were enrolled, and of those, 11 had rejection and 26 without rejection were looked at longitudinally. In addition, there were 127 patients with infection that were also analyzed. One limitation of the study was that this was a predominantly Caucasian population where patients received basiliximab induction, which is not the standard of care in most of the US, where 80% or so of patients with kidney transplants receive induction thymoglobulin. So all torculovirus measurements in the study, around 3,000 plus samples from the total cohort of 386 patients included in this graph. And you see a very similar trend as in the thoracic transplant studies and the bone marrow transplant studies, where there is an uptick in the TTV viral loads, where it goes from initial numbers of around 1,000 copies per ml to almost 1 billion copies per ml by around 3 months post-transplant. And then it starts going down over time and settles down to around 1 million or so at 12 months post-transplant. Upon creation of the ROC curves for prediction of rejection on the left or infection on the right, the authors found that each log increase in TTV decreased the odds of rejection by 22%. The median for this was around 10 to the power 6, which is 1 million copies per ml, and increased the odds for infection by 11%, with the median of slightly above 10 to the power 8 copies per ml, with reasonable AUCs. The authors suggested, based upon this paper, that around 10 to the power 7 copies per ml or 10 million copies per ml may be ideal for optimal immunosuppression. And these samples were drawn around 14 days before the rejection episode and around 30 days before the infection episode. So there was a lag time, and this is interesting because prediction appears to be possible based upon these numbers. Similar studies have been done in liver transplants. I'm not going to go through them for the sake of time, but I'd be happy to answer questions in case there are any at the end of this discussion. So these data I shared with you have led to the design of a randomized trial in lung transplants currently being done at Vienna and Hanover in Europe, where patients will be randomized to TTV-guided immunosuppression versus standard of care. Now, the reason why I've showed this data to you is this is mostly European data, and we do not know whether they can replicate in the US or not, because viral dynamics may be different, immunosuppression is different, population characteristics are different. So to investigate this further, we've been working on a study with Natera here at VCU. So in preparation of the study, which I'll show the design of the next slide, as an initial pilot, they looked at 413 patients without rejection in a historic cohort. And the patterns of TTV replication here, which you can see on the left, are very similar to what I showed you from the initial Viennese data on kidney transplants, where once again, early post-transplant, the TTV viral loads are low, and then they go up around 3 to 4 months, and then they start going down over time. Now, these are pooled samples, but they're not longitudinal samples. And you can see longitudinal sample distribution for 50 patients on the right, where once again, the patterns seem to be overall preserved. And across the board, if you look at these numbers, they're definitely higher than those without transplants. And you can see that in the blue bar at the bottom, which is around 1,000 copies per ml or below for non-transplant patients. So therefore, these data suggest that even in an American population of those without rejection, these patterns of distribution for TTV remain preserved. The next step is the study which we are doing at the current time. We've selected 98 kidney-only transplants for this, of which 37 are controls, meaning no rejection within the first year of transplant, 30 with antibody with rejection, 12 with T-cell with rejection, and 18 patients with BK virus, viremia, or nephropathy. Each patient has 4 samples, first from around the time of transplant, second from around 30 days before the clinical event, third at the time of event, and fourth post-resolution of event, or 1 year post-transplant, whichever was earlier. And we hope to share this data with you soon. And with that, I'll end this presentation, and thank you for your attention.
So our next speaker is Dr. Pedro Ventura, who's going to talk about how to apply this quantification of donor-derived cell-free DNA in the patient who has received simultaneous pancreas and kidney SPK patients. Dr. Ventura is a transplant nephrologist from Hospital Clinic of Barcelona in Spain. He finished his medical degree and residency in nephrology in Portugal, and then he moved to Barcelona, where he obtained his doctoral degree from University of Barcelona on donor-derived risk factor for pancreas transplantation. Dr. Ventura is a researcher at IDIBAPS, and his major research line focused on novel biomarkers for diagnosis of acute rejection in pancreas transplant recipient. Dr. Ventura.
Well, Thank you for the kind introduction, and I also would like to thank Natera for the invitation to present our work here today. And I will be talking to you during the next 20 minutes or so about how we applied the quantification of donor-derived cell-free DNA in pancreas kidney transplant recipients. I would just like to highlight that this was a study that was partially funded by a Spanish national grant and also by Natera. When we talk about pancreas transplantation, there are some features that are similar to other solid organ transplants, like pre-existing risk factors that are donor or recipient related. But then there are some unique features that distinguish them from other solid organ transplants. We measure and we monitor function by measuring glucose, A1C hemoglobin, C-peptide, and also by monitoring beta cell autoantibodies. But then when we talk about trying to establish graft dysfunction, we rely mostly on amylase and lipase. And this is what's unique about pancreas transplant, is that most of the pancreas transplants performed, patients maintain their native pancreas, and they maintain their functioning native pancreas, particularly the exocrine function, since the endocrine function is the one that was dysfunctioning and therefore required the pancreas transplant. Therefore, when we evaluate amylase and lipase, we must always take into account that this patient maintains their native pancreas functioning as well. We also monitor donor-specific antibodies, as in other solid organ transplant. And then there's this other unique feature, which is on imaging and evaluation. Ultrasound is a very good, or CT scan are very good tools to evaluate the graft after the transplant, but particularly in long-standing functioning grafts, like beyond 5 or 10 years, ultrasound, particularly by ultrasound, it might be harder to identify the pancreas after the transplant. Since it's a glandular-like and due to the fibrosis after the transplant, this by ultrasound, it can be hard to identify the organ. And even if we can identify, it can be a caveat towards the performance of a graft biopsy. Therefore, altogether, this leads us that we need perhaps new tools that aid us in the monitoring of pancreas transplant. Moreover, we know that pancreas transplant has a high incidence and one of the highest among abdominal solid organ transplants of acute rejection, among between 20 to 35% lifelong and about 15 to 20% during the first year after transplant. But when we look at the biomarkers we have and we use, we see that amylase, there is no correlation with any graft rejection in the post-transplant period. But when we look at lipase, we can see that in patients with acute rejection, any type, there is an increase. But for example, if you look here at this darker gray column here, you can see that in antibody-mediated rejection, there is literally no difference in patients which have antibody-mediated rejection and those without rejection after a pancreas transplant. So it makes it rather specific for acute rejection, but not very sensitive for some kinds of rejection. But then we can look at the other biomarker, donor-specific antibodies. For those of us who also follow up other patients, other solid organ transplants, such as kidney or heart transplant, we know that the development of DSAs is not pathognomonic that we have an acute rejection. And this is what was observed here in this study by Pablo Uva in Argentina. When he did surveillance biopsies for patients with de novo DSAs without clinical signs of acute rejection, he identified that only half of these patients eventually had histological features of acute rejection, meaning not all DSAs might be pathologic, and meaning that not all these patients with DSAs require treatment or have an indication for a graft biopsy. We can also say that, okay, but in SPKs, since donor is the same for both organs, we can use kidney as a surrogate marker. Kidney is an organ that is easier to monitor. We have serum creatinine, which is more variable and perhaps more reliable. We can easily access kidney graft for a biopsy, and we could use it to monitor pancreas graft. But here on this concomitant biopsy performed to both organs, what you can see is that when you have a pancreas graft dysfunction, only half of the patients had also a kidney graft rejection as well, with more than 40% presenting unique pancreas rejection, which means that even in the absence, even when we have a kidney from the same donor, we still need to make an accurate diagnosis for pancreas acute rejection. Most importantly, biopsies performed on these patients with pancreas dysfunction, meaning an increase in amylase, lipase, or a change in glycemic control, acute rejection was diagnosed only in 39% of those, which means that more than 60% didn't have an acute rejection despite having a pancreas graft dysfunction. This translates that even with the current biomarkers, we need to have a better accuracy towards the decision on to treat or not, and most importantly, also to do a biopsy or not to do a biopsy. And this is where DNA comes into play. DNA makes us unique. We can distinguish each other through DNA and through DNA transcriptions. So if we could sequence the whole DNA from between donor and recipient, we could distinguish between the two, and we could use it to monitor, particularly to monitor graft rejection. So what we can do with this is one of the techniques used to monitor donor-derived cell-free DNA. If we sequence a sufficient and enough amount of genes, then we can identify single nucleotide polymorphisms, or SNPs, that are unique to donor and unique to recipient. SNPs are present in the whole genome, usually non-coding areas, but if we can sequence this amount of genes, we can explore and identify using computational models of differences between what is donor-derived the cell-free DNA and what is host cell-free DNA, which means that despite not knowing the genetic background of the donor, even we can still use it to differentiate between donor and host cell-free DNA. And this was applied to several other organ transplants. It was applied to kidney transplant, to liver, to heart, and even to lung transplant. And we know that in these organs, there was a correlation between the amount of donor-derived cell-free DNA and acute rejection episodes. Therefore, what we did afterwards, and we did here, was to try to explore what was the ability of donor-derived cell-free DNA to correlate with acute rejection during pancreas transplant acute rejections. So what we did was a retrospective study in which we included patients, SPK recipients from our center, and we compared and analyzed those in which we had a blood sample suitable for evaluation of donor-derived cell-free DNA, and it was extracted at the same time point in which we had a graft biopsy that was accurate for a diagnosis. And what we did was we compared the results of donor-derived cell-free DNA between those in which the biopsy there was an acute graft rejection and those in the biopsy there was no rejection. And here you can see the demographics of our cohort. There are no major differences regarding most recipient demographics, such as age, gender, diabetes type, or BMI. But you see here that regarding biomarkers, you can already see here that patients that had an acute rejection had a higher lipase compared to those with no rejection, and there was a tendency towards a higher CPRA compared to those without rejection. Moreover, you can already see here in between that serum creatinine, and I would like to highlight this, serum creatinine was not different between those that had an acute rejection in the pancreas graft and those that had no rejection. And also here on the bottom, you can see we included biopsies that were performed either for cause or surveillance biopsies. And you can see that rejection, those patients with an acute rejection had a higher rate of biopsies performed for cause, which was expectable. Whereas non-rejection, most biopsies were those performed per protocol or surveillance. And this is our flow chart on how do we monitor and for you to better understand why we included these biopsies. Here at Hospital Clinic, what we do is after a pancreas transplant, if the patient has an acute or suspected acute rejection episode during the first 3 weeks, then we do a graft biopsy during this period before day 21. If there is an acute rejection, we treat. And after treatment, 4 weeks after finishing the treatment for the acute rejection episode, we do a surveillance biopsy. If there is persistence of acute rejection, we keep going with the treatment or increase on the treatment protocol until we have a negative biopsy for rejection, which afterwards we do a surveillance biopsy at 12 months. On the other hand, if there is no rejection during this early time post-transplant, during these first 21 days, we just do a surveillance biopsy around day 21, and afterwards do the 1-year biopsy. And here you can see this reflected on the graphic on the right. These are the biopsies that were included in the study. And you can see here on the blue columns, there are those biopsies without rejection, and in the red columns, those biopsies with rejection. And on the horizontal dashed lines, what you can see is 21 days, the first 3 weeks after transplant is our protocol, and the 12 months after transplant. And you can see that during these first 21 days, we have several biopsies that had an acute rejection during this period of time. Some of them performed for surveillance here in the solid red lines columns, and some of them performed for cause here early on in the post-transplant, here with the dashed red columns. Afterwards, there is this period in which we see these biopsies with no rejection that were performed for surveillance. These were either late, early post-transplant surveillance biopsies or biopsies that were performed for surveillance after an acute rejection episode. And after one year, what you can see is most biopsies are obviously performed for cause. So how did donor-derived cell-free DNA perform? Overall, we found that in acute rejection episodes, the rate or the percentage of donor-derived cell-free DNA was higher in those that had an acute rejection confirmed by biopsy compared to those without acute rejection. But we did an analysis 2 ways. We evaluated not only donor-derived cell-free DNA as a percentage, meaning as a correlation between the amount of donor cell-free DNA compared to the total amount of cell-free DNA that was extracted from the sample, but we did also a correlation just evaluating the amount as copies per milliliter of donor-derived cell-free DNA without taking into account the total amount that was available in the sample. And this was explored as copies per milliliter, and these are the total amount of donor-derived cell-free DNA. You can see that using this second approach, it remained higher, the amount of donor-derived cell-free DNA compared to those in those with rejection compared to those without rejection here in the blue boxes. But then we explored a different way. We know that during the post-transplant period, particularly in the early post-transplant period, we have other factors that might lead to organ injury, ischemia, reperfusion, donor characteristics, surgical complications, in which they all might lead to organ injury and therefore to an increase in the release of donor cell-free DNA into the bloodstream. Therefore, we separated our analysis between those biopsies that were performed before day 45 and those biopsies that were performed beyond day 45. And I would like you to focus on the left boxes. You can see that before day 45, there were, even though there was a tendency towards a higher rate of donor-derived cell-free DNA in those patients with rejection, nonetheless, these did not attain statistical significance. But when we compare those beyond day 45, first, I would like you to focus on the blue boxes. You can see that even in non-rejectors, those without rejection in the biopsy, there was a significant decrease in the amount of donor-derived cell-free DNA when it was determined beyond day 45, which kind of corroborates our perception that during this post-transplant period, there might be some other factors influencing on the amount of donor-derived cell-free DNA. Therefore, afterwards, we focused our analysis in this cohort, in a cohort that was of biopsies performed beyond day 45. And if you focus here, what you can see is that beyond day 45, there is a significant difference in patients in the amount of donor-derived cell-free DNA in those patients that had acute rejection compared to those without rejection. You can see here that it was below the traditional cutoff of 1%. Nonetheless, when we look at the amount and the absolute quantity of donor-derived cell-free DNA, you can see that using a cutoff of 70 copies per milliliter, all the samples with acute rejection were above this cutoff. But how does this compare to the current biomarkers? Beyond day 45, we can see that there was no difference in the amylase levels between those with rejection and with no rejection, but we can see that those with acute rejection had a higher lipase compared to those without rejection. So this leads us to question, do we really need donor-derived cell-free DNA? Because lipase apparently is correlating between and differentiating between rejection and no rejection. But when we measure and we quantify the performance of these two markers, we can see that donor-derived cell-free DNA, either as a rate, as a percentage, or as an absolute quantity in copies per milliliter, outperforms lipase towards the diagnosis of acute rejection. Most strikingly is when we use this absolute amount of donor-derived cell-free DNA, we can see that we achieve a negative predictive value of 93%. And also, we achieve a specificity of 93% as well, meaning that if you have an amount lower than 70 copies per milliliter, we can be rest assured that most likely we don't have an acute rejection episode in the pancreas graft going on. Whereas if there is an increase above this level, also they are highly likely in the presence of an acute rejection episode. Therefore, it outperforms lipase and it can help us better diagnose these patients. But as I mentioned earlier, we also correlate this with the assays. We also monitor donor-specific antibodies in the post-transplant period. So how do these correlate with donor-derived cell-free DNA? I would like to hold some enthusiasm towards this slide because the sample is really small with only 3 cases and only 1 case of antibody-mediated rejection. Nonetheless, what you can see is a clear difference between those that had positive DSAs at the time of biopsy compared to those with negative DSAs. Moreover, you can see that there are 2 patients here that have DSAs but have no histological features of acute rejection or of antibody-mediated rejection, which means that it can perhaps also aid us to diagnose these patients as well. Obviously, there are some limitations to this study. It's a small sample cohort, it's single center, and it's retrospective. No actions were taken upon the results of donor-derived cell-free DNA. Moreover, we have a rather high number of biopsies that were performed during this early period, in which we found no difference between the two, the rejection and no rejection. And finally, we included indeterminate biopsies and categorized them as acute rejection. This may be controversial, but when we performed the same analysis, excluding those that were categorized as indeterminate, we also found the same results with significant increase in the donor-derived cell-free DNA compared to those without rejection. And finally, we have no kidney biopsy, and this increase in donor-derived cell-free DNA could be related to dysfunctioning of the kidney graft, which is has been more demonstrated that there is a correlation between donor-derived cell-free DNA and kidney graft acute rejection. As I mentioned earlier, the serum creatinine was similar between the 2 groups, and in most of the biopsies there was no kidney graft dysfunction simultaneously. And most importantly, these are histological correlated to the pancreas graft, and therefore I think this kind of levels a little bit this absence of kidney graft biopsy. So I think our data provides solid evidence that perhaps we need to include donor-derived cell-free DNA in our arsenal to monitor pancreas grafts. We can still use amylase and lipase. We can still monitor donor-specific antibodies, but perhaps we need to add donor-derived cell-free DNA and integrate the data all together. Because DSA and donor-derived cell-free DNA, they are not part of the same 2 parts of the same picture. Perhaps they are the same picture, but just 2 sides of it. And they are complementary rather than interchangeable. And this is an approach that we could use in the clinical setting. Can you still use amylase and lipase, and we can still do DSAs. But in those with DSA negative and with normal amylase and lipase, we can keep monitoring donor-derived cell-free DNA. And if we have a normal value, then perhaps we can rest assured that we have a stable graft, and we just need to keep monitoring them long term. On the other hand, if we have an increase in donor-derived cell-free DNA, our first attitude should be to repeat it and to exclude other causes that might lead to an increase. In an SPK, for example, it might be a kidney graft dysfunction that could lead to this increase in donor-derived cell-free DNA. But in the absence of other causes, and shall we repeat and it remains high, then perhaps it precludes us and it incentivizes us to do a graft biopsy to exclude a possible acute rejection. Therefore, and afterwards treat accordingly. On the other hand, if we have a positive DSA, I think right now this data doesn't provide enough evidence to decide to biopsy or not biopsy according to donor-derived cell-free DNA. Nonetheless, it does provide evidence that we can use it to monitor. So if you have a positive DSA, perhaps we should do a graft biopsy. In the absence of the rejection, just keep monitoring both biomarkers. But if we have a good rejection, treat accordingly and use both biomarkers to monitor the response to treatment. And this is an approach that we could use on the clinical setting. I would just like to end by thanking all those that are involved in the clinical activity of pancreas transplant here at Hospital Clinic, to all those involved in our research program on transplant immunology and transplant research, pancreas transplant research, rejection, and finally, to all patients and families who are the core of our studies and that participate and are eager to collaborate in our studies. Thank you very much. I would finally like to welcome you to Barcelona. We have sun all year round. We have the largest cathedral under construction in the world. We have tapas. And finally, you're not going to be able to see the three guys playing there, but we still have great football there. Thank you very much. And I'm glad to take any questions.
Thanks a lot for your attention. I hope you have found this presentation informative. And now I open to the floor for live Q&A. Great. So the first question is going to be for Dr. Halloran. There is a question that they said, is there a higher correlation of donor-derived cell-free DNA, MMDX, and DSA? So like if the DSA has a high MFI or it's complement binding positive, does it make any difference?
Yeah, that's a complicated question. We don't have the answer. The details of the DSA positive samples probably will influence the regression predictions in the DSA positive samples. Our big priority right now is actually to find out why the DSA negative samples are negative, and if another look at those, this is One Lambda applying the algorithms and Luis Hidalgo interpreting them. But it really looks like DSA negativity is quite robust. It's 97% agreement between DSA negativity in the One Lambda samples and DSA negativity in the local centers doing different samples. So it's a robust finding, and really we can get some additional information by studying the details of the DSA positive samples. But really, in order to make the DSA predictions better, you're going to have to do something to find antibodies in the DSA negative samples. I think there are such antibodies, but they may not be identifiable with the platform that's available. Anyway, that's a theory of mine.
Oh, great. Thanks, Phil. The second question is for Pedro. The question is, for the pancreas transplant, 48% rejection group who are CPRA positive, did you see any correlation between the percentage, like of a fraction of the donor-derived cell-free DNA showing DSA positive versus DSA negative in this CPRA positive group?
Thank you very much for the question. Actually, we did not correlate with the CPRA level. We only correlated actually those with actual donor-specific antibodies. As I mentioned, only there are these three cases, biopsies performed beyond day 45 that had this positive donor-derived cell-free DNA and have DSAs. And in these cases, there was a correlation. Those that were non-DSAs, actually, we did not specifically look at those patients with positive CPRA, but with non-donor-specific DSAs, we did not look at it, no.
Okay, great, thanks. Phil, there's another question for you. They said, what other variable do you think is reasonable to include in this analysis other than the 4 variables that you discussed?
Yeah, it's a good question. Obviously, we have the question we were asking was how to interpret 2 different tests given time post-transplant, and that was the relative performance of the different tests and predicting at the time that a clinician is facing a patient with indications for a biopsy. I suppose you could introduce a whole lot of other variables, such as the previous history of the patient, previous rejection episodes, etc. So you could, in a multi-center test, you don't have an unlimited, in a multi-center study, you don't have an unlimited amount of information about the individual patients. But predictions would always be better if you add additional variables that you know will have some weight in a particular patient, such as the prior history. So all tests should be taken into account and interpreted in relationship to prior probabilities. And the prior probabilities would influence the predictions.
Okay, thank you very much. Pedro, again, the question is for you. They said like in most centers in US, they don't do pancreas biopsy. So if you monitor this patient and the fraction become positive, how do you think they should approach those patients?
Thank you for the question. I think right now that's the $1 million question. We did identify that those patients with a positive donor-derived cell-free DNA, there was a correlation with acute rejection. We correlated with the pancreas biopsy. We don't have a cohort in which we did not treat. I think for the time being, we found that lipase was also a good surrogate marker, fairly good. I think right now, based on what we experienced, is that is giving us an add-on information. We explored if we matched lipase and donor-derived cell-free DNA, if we could improve the performance towards the prediction of rejection. We did not find an improvement in performance if we used both markers. I think right now in pancreas, and for centers who don't do a biopsy, I think donor-derived cell-free DNA provides you an extra feature. Obviously, if you have an increase in any of the markers, have a positive DSA, and if you have an increase in the lipase, obviously it's most likely that you also have an acute rejection. But as stated, I think the negative predictive value is still the most important factor here, is that if you have an increase in amylase, if you have a suspicion like a patient with abdominal pain or any other features of pancreas rejection, and you have a negative donor-derived cell-free DNA, you can rest assured that it's likely that you don't have an acute rejection. And therefore, in these cases, perhaps it's the negative value that it's providing you rather than the positive value. I don't think our study was powered enough to assume a positive value of the donor-derived cell-free DNA towards treatment and to skew clinical practice towards treatment. I think rather the other way around. If you have a high value, then perhaps we can rest assured that it's highly likely we don't have an acute rejection, and this increase in lipase is secondary to other features, medication, native pancreas, or other features for sure. But I don't think it's right now we can decide the treatment of an acute rejection based on the donor-derived cell-free DNA.
Thanks a lot, Pedro. Dr. Gupta, the next question is for you. Do you think, apart from TTV, is there any other virus that can help us in the status of immune system?
Known about BK virus, CMV, and EBV as also surrogates for immune exposure. The problem is that by the time you detect them, the patient already is sick with those problems. So yes, we can use those viruses to measure immune exposure, but the unique thing about viruses, it's essentially a harmless virus from what we can tell so far. It is not associated with human disease. So detection of the virus can be a harbinger of problems that may lie ahead for the patient.
Thank you very much. Go through the questions.
I do have a question for Pedro if there are no other questions.
Sure, you go.
So I may have missed this. Did you measure lipase as a discrete marker, or was it a delta lipase that you used for your analyses?
I'm sorry, I couldn't understand the question. I'm sorry about that.
So did you use the change in lipase over time to predict rejection, or was it lipase as a discrete number at the time of the event?
It wasn't a longitudinal analysis. It was only cross-sectional. So it was only at the time of the rejection. So it's basically a cross-sectional analysis of that specific time point. That would be the ideal. Is what you guys have ongoing and the study that you have ongoing to evaluate the intra-individual also changes in donor-derived cell-free DNA. Perhaps that is even more relevant than only the cross-sectional analysis comparing different patients. So this was only a one-time point analysis, so we can't predict or have that ability to predict what were the values prior to the acute rejection or after the acute rejection episodes.
Thank you.
Okay, thank you very much for your participation. And our speaker, thanks a lot for great presentations. I enjoyed and I learned a lot. I hope all the audience has found this session informative. And again, I appreciate the great question and making it interactive. And I hope that you enjoyed the CIAT conference, despite the fact it's virtually this year too. Have a great day.